Good morning, everybody. Welcome to Endo Echo. We're all feeling recharged. The team was in Albuquerque last week at the third Meta Echo meeting. It was a get-together basically for all of this planet's echo programs. There were 650 participants, and pretty remarkable. People from Africa, India, Canada, Europe, and probably almost all of the hubs in the United States were there. And you know, the work that people are doing in echoes is mind-blowing. Everything you can imagine in medicine, in other areas, particularly in education, just incredibly exciting. And you really get to feel like you are part of a worldwide movement. So good, so good. There are still, you know, in the endocrine echo world, there are not that many of us, half a dozen perhaps. And the issues that we discuss, because we get together kind of as a group and say, all right, well, how's your endo echo going? How's your endo echo going? And you know what? We all basically have similar experiences. And they relate to stuff that we've talked about before, like how do you support yourself? You know, where's the money coming from to support your program, and what are your plans for staying afloat in the future? And how do you get people to submit cases? So I'm throwing down the gauntlet. We are here every 2 weeks. We know you're seeing a lot of patients. We know a lot of those patients have endocrine disorders that you would probably like to discuss or get more in the weeds with, or you're thinking oh, maybe I need to send this patient to an endocrinologist. And we'd love to talk about those cases, but we're not seeing that many cases submitted. So think about it, you know, as you're going through your day and you're seeing patients and you're kind of scratching your head and saying, gee, I'm doing this, but maybe, maybe I'm not that comfortable, or maybe I want to get a little bit more detail. Just make yourself a note and save those cases, and let's talk about them here. Because if you're scratching your heads about some of these issues, it's a certainty that everybody else who's on with us scratches their heads at the same time. And if we can all scratch our heads in unison, we can get rid of those annoying uncertainties perhaps, and resolve some of those questions. That's really what we feel that we're here for. We know, because certainly I know, that when I talk to somebody about a patient, I generally remember that forever. And I know that it's true for you. So think about it, you know. You've got two outboxes. You can either refer that patient for an endocrine consult, which will happen a year from now, or you can put that note to yourself in the echo outbox and present that case sometime in the next 2 weeks, because we're here every 2 weeks, and let's answer those questions. And if we can't answer them, we can expedite getting those patients seen by our endocrine service. So I ask you again to just think about it that way. This is the way you can answer those sort of areas of uncertainty. You can then apply what we discussed to your patients and get their care moving in the right direction. So, end of lecture. End of lecture number one. You have to sit through another lecture. So there are a couple of folks on the board who, so Lou Fink, MD. Hello. Can you tell us who you are, where you are? Dr. Fink? Okay. Does anybody, now that I've provoked you, have any patients they want to discuss? The adult male hypogonadism? For just a couple of minutes, and I'm glad that we only have 15 minutes to talk about this, because it's an area that is sort of loaded with uncertainty and speculation, and we're never 100% sure what to do, but it is something that comes up all the time. All right, so what we're talking about here are men with low testosterone levels and how to manage them, because it's just like with vitamin D. It seems like the more you measure, the more you find low values, and the question is it reflecting an important medical condition, or is it just something that is part of life in 2017? So we'll try to sort this out. There's a reference which is from Mayo Clinic proceedings from last year, from which I've taken these slides. And there's a little bit more detail there, but I'm going to give you the highlights. So just in terms of definitions, let's just remember, primary hypogonadism, testicular failure. Something's happened to the testes in this adult man. All right, this is somebody who has gone through puberty, who has reached adulthood, but now has low testosterone with evidence of primary testicular failure. So that could be someone who had a testicular trauma, who had mumps, who was exposed to chemotherapy, or perhaps has Klinefelter syndrome, right? So these patients are defined by low testosterone, but usually these patients have very low testosterone. And I would tell you that a patient who has a testo under, say, 150 has a significant organic disorder, right? And if you wanted to say, all right, what number below which am I really sure there's something structural going on, I would say 150 might be your cutoff. But these patients are going to have elevated LH and FSH because their pituitary is working normally and is responding to that low testo by trying to stimulate more testosterone production, right? So they've got normal pituitary function, but testicular failure. Patients with secondary hypogonadism are going to have low testo with LH and FSH levels that are inappropriately low. In other words, the pituitary is not responding to those low testos by secreting more LH and FSH. But they don't have to absolutely be low. They could be in the normal range, and they're still inappropriate to the low testo level. And you might, again, sort this out. Patients, a guy with a testo of 130 who's got an LH in the normal range, I suspect has a pituitary disorder, right? So again, very low testos suggest a structural disorder, either primary testicular failure or a pituitary defect. It's the next group of patients who are the patients we're now seeing with such frequency. And those, we want to separate those out. So we're going to call this adult onset hypogonadism. They've got a low testo, that is below the lower limits of normal in your lab, who don't have elevated LH and FSH. So those patients may have testos, say, between 280 and 150. And we see those patients all the time. And the question comes back, why did we test testosterone? Why did we measure it? Because if you measure it, it should be for some good reason. And what I want to encourage you to do is to measure testo in response to a patient complaining that they're having symptoms that are typical of low testo, right? So the symptoms of that would be loss of libido, inadequate erectile function, okay? Those would be the symptoms that you'd want to think about. Patients complaining of fatigue, lack of focus, lack of initiative, you know, that's a gray area. And that it doesn't speak to low testo specifically. So when we measure testo in response to those symptoms, we are oftentimes going to be challenged because we're going to find testo values that are not normal, and we're going to be hard pressed to say that those symptoms are caused by the low testo rather than the low testo caused by some other issue which may be non-physiologic. Okay, so that's the issue, is measuring testo where low testo is likely to explain the symptoms patients are complaining of. And it's common, right? Maybe 10% of men between 40 and 80 in this paper, but I would suggest that those numbers rise with advancing age. And, you know, in patients in their 70s is maybe 20% or more patients. And patients without clear-cut symptoms of hypogonadism are going to be at the lower end of that spectrum. Patients with typical hypogonadal symptoms are going to be much more likely to have elevated or suppressed testo levels. So the comorbidities, the things that are likely or commonly associated with adult male hypogonadism, are obesity, metabolic syndrome and type 2 diabetes, obstructive sleep apnea, anxiety and depression. Patients with HIV/AIDS, almost all have hypogonadism. Patients with opioid use and substantial cannabis use typically have low testos. Patients on glucocorticoids, tricyclics, and heavy smokers may have low testo. So these are the scenarios in which the finding of low testo is going to be fairly common. So here's my recommendation. Test testosterone when you have real good reason to be suspicious that there is something going on that's explicable by low testo. So patients with type 2 diabetes, you may want to test if they have symptoms of hypogonadism. Patients who have osteoporosis or have had a traumatic fracture with minimal impact, you know, you could be suspicious that testosterone deficiency is present. Patients who have been exposed to a variety of the drugs we've talked about, patients who have been detected to have a cellular mass or trauma, patients with HIV/AIDS, patients with end-stage renal disease on dialysis, and patients with sleep apnea. So this can we make that smaller? Okay, thanks. So I would tell you that the threshold for low testo, and the threshold at which you might start to think about whether testo replacement is reasonable, is in that range of 280 to 300. Values above that we should just call normal. Values below that, we can entertain the question of whether maybe the patient might benefit. Again, now that we know the number, can we do something that's going to actually help the patient, right? So if we look down here where this is, okay, these are patients with testo values above 300 and with LH values that are in the normal range, right? So this group, this is normal, right? Patients in this group are patients who have normal testo levels, but have elevated LH levels. And we see this in a couple of scenarios. We see this in patients as they age, okay, whose testicular function begins to fail, and there's compensatory production of LH to try to drive more testosterone production, right? So their testes are able to respond, produce enough testo, but it takes more drive to do that. But they've got pituitaries that are up to the task, right? So the pituitary is able to stimulate more testo secretion. I would say in this group, some of those patients may go on to hypogonadism, but I would leave them be, okay? in this quadrant, we are talking about the group of patients we're actually interested in today, whose testo levels are low. They're below 300, and whose LH levels are not elevated. Okay, so I'm not going to say they're low, they're just not elevated. This is the group of patients who have, there are really two groups of patients here. One is the group of patients with adult onset hypogonadism, this relatively new entity. And these are the patients right about here, whose testo levels are in the, say, 250 to 300 range. Right, so they're just a bit below normal. And this is that gray zone. These patients, right down here, whose testo levels are really low and whose LH levels are low, these are the patients who likely are going to have a structural disorder of the pituitary. All right? So again, you want to, this box, in your mind, divide them up into two groups. Right? One group, the patients with the really low testos, have a pituitary disorder until proven otherwise. This group, where the dot density is pretty heavy, these are the patients we're seeing now all the time, who have maybe a little bit of low testo, but whose pituitaries don't really think they have low testo, right? Because they haven't tried to stimulate more production. This is the group that we're particularly interested in today. Any questions about that? Okay. And as you can see, up in the right corner, is that a question?
Yeah, Krista, go ahead.
Sorry, Dr. Klass. I just want to back up just a little bit. So for the primary, where you have the low T, does it have to be both FSH and LH need to be elevated?
They're almost always both going to be elevated.
Okay. Okay.
Anything that is so destructive to the testes is going to affect. Remember, LH stimulates Leydig cells to produce testosterone. FSH stimulates seminiferous tubules. And the trauma that caused testicular failure is going to affect both. There are rare circumstances where one or the other is elevated, topic for another discussion, but figure both will be elevated.
Perfect, thank you.
And as you can see up here, in this compensated hypogonadism is more common in the older group. Secondary hypogonadism occurs through all groups, but that seems to be a greater function of aging. So when you find patients with low testo, okay, because we're finding them all the time for whatever reason we've tested, the way to look at this is the following, that about 30% of those patients will have no obvious cause for their low testo value, okay? And then when we go to the next slide, of that group, I'm sorry. The group with specific medical conditions is a small percentage of this overall group, all right? And when we look at what those might be, we take that 11% who have some definable medical condition. You can see here the sorts of conditions that you might identify. So this very crowded and unreadable slide is in the handout or in the materials for today, but it's essentially an approach that is laid out to evaluating a patient for hypogonadism. Oh, that's great, actually. But the key here is to look at why we're measuring testo levels and to try to be cognizant when we order that testo that we may be opening a can of worms. And that once we have found it, we want to try to sort those out. So patients with testo levels above, say, 280, down in this box, just call them normal and move on, right? Patients with lower values, you want to think about any of those comorbidities we talked about. And then we're going to have to, at some point, make a decision about whether treatment is warranted or not. And we need to know that when patients have symptoms that are consistent with true hypogonadism, who have hypogonadal symptoms, loss of libido, inadequate erectile function, those patients are likely to have a favorable response to hormone replacement therapy. Patients with symptoms that are much more vague and uncertain, fatigue, loss of focus, are much less likely to have a favorable response to therapy. But there's no harm in considering a therapeutic trial. You know, when in doubt, there's no harm in a trial of replacement. And patients tend to vote with their feet, so that if they're really getting better, they tend to stick with therapy. And 6 months out, they're still using therapy. And patients who have not really noticed much benefit tend to start becoming less compliant. And that may be one of the best indicators of whether your therapy has been effective. So if you're going to initiate therapy, ideally it's going to be with transdermal therapy, because the absorption is very predictable, blood levels tend to be quite stable, and the only thing that holds us back from doing that is insurance coverage. But if you've got a patient who can be treated with transdermal testo, that would be my recommendation. And you might want to try after a month of therapy to recheck their testo levels, make sure they've reached the therapeutic range, and then give them several months, perhaps 3 to 6 months, to see if there's been a therapeutic response. If there has not been, despite having reached an adequate testosterone level, you may want to reevaluate whether ongoing therapy is worthwhile. And it's a couple of minutes after 9, and I think we can continue this discussion at another point, but please check that reference, and we will loop back, and I'd love to hear what your experiences with testo replacement have been, because I think that, again, there's real opportunity here to identify men who have a treatable disorder, who can really do better. And then there are a lot of patients out there who are not likely to benefit from therapy. And we want to try to target our therapy to those guys who are most likely to benefit from replacement therapy. Questions, thoughts, anything? Otherwise, we'll...
Dr. Van Gilder?
Yes. Hi, Kim.
Sorry, quick question.
Yeah.
So I just inherited a patient who has primary, I guess, adult onset hypogonadism, who was seeing Dr. Ann Owens, but she's not practicing anymore. So I'm not sure if it's possible to try to get records. Do you know where her records are?
Well, so she's been out of practice for a good few years.
Mm-hmm.
I know that for some time, you know, it was possible to get the records. I don't know what's become of her records. Anything in the patient's history that tips you off to what the etiology might be?
Well, he said he's been on injectable testosterone for 15 years. He was not able to father children, kind of the classic pattern. I just inherited him because he saw a new doctor in Fallon who wouldn't do injectable testosterone. He tried the patch. The patch was not working. It kept falling off. He just didn't feel it was getting him the proper levels. I tested his blood and his level was 53.
Okay.
For testosterone after a month on patches. So I restarted his testosterone injections while I'm waiting to try to get records.
Sure. So I'll tell you what this guy has.
Okay.
All right. He's got Klinefelter syndrome.
Oh, yeah.
I'm sure. He's sort of middle-age-ish, had a problem with fertility, and has been on therapy for a pretty long time. That almost certainly is a Klinefelter's guy. If you examined him, I'll bet you his testes are pea-sized. And you can confirm that without getting other records, because you can very cheaply get a karyotype done if you want to firm it up. Or you might just say, did anybody ever say Klinefelter syndrome? but I'm sure that's what he's got. And again, that very low level of testo for that. Testo patches are horrible. I would never prescribe them. They just don't work. And they're incredibly irritating. You know, it's typical for somebody using those patches to walk around with big bullseyes every place they've applied a patch. They're just very irritating. Transdermal testo with androgel or testim, much better. And again, the only issues about using those therapies is the patient's got to do it every day. And he needs to know that there could be skin-to-skin transfer if someone else rubs against the area where he's applied his gel for, say, 3 or 4 hours after. So that's an issue. But if he prefers injections, that's fine. And then it's just dose titration. And the thing about dosing is that more frequent gives you better coverage than less frequent. Although, you know, in the old days at the VA, we used to have our patients take a big dose every 3 weeks. The problem with that is that the absorption tends to have tremendous peak and valley, so that, you know, you inject 300 milligrams, by day 9 or 10, the serum testo is probably 2,000. And that affects people, you know. You start having issues with really aberrant sexual ideation, really disturbing dreams, and even some aggressive behavior. And then by week 3, the levels are probably down to 60, you know, and patients are feeling pretty terrible. So I try to lower the dose and shorten the interval. So ideally, 100 milligrams once a week really doesn't give you much peak and valley, but that's 100 milligrams deeply intramuscularly injected, so it's kind of unpleasant. So maybe 200 every 2 weeks gets you there. Some patients are willing to inject themselves. Some patients have a spouse who will do the injections. I'm not a big fan of injecting into the quads. You know, you can do it, but the risk of just sticking the needle into the periosteum is pretty high. I don't know, what do you think about? Yeah, I don't like to do that. Yeah, you know, so I like to do it in the glute. I think that's the best place. You know, it's the safest injection, upper outer quadrant. You stay out of trouble that way, but hard to do that yourself. You agree? That's tough. That's a tough read. So you want to have somebody else do that, and so the best situation is spouse or partner being trained to do those injections. I think that's safe and humane and works pretty well. But I'll bet you he has Klinefelters.
Thank you.
Okay. All right. Thanks, everybody. We'll see you in a couple weeks.